Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to be talking about tapinarof cream, which is a 1% as a novel topical therapy for adult plaque psoriasis. Our moderator this evening is Dr. Firas Ujier, who is Clinical Assistant Professor, Department of Internal Medicine at Philadelphia College of Osteopathic Medicine and President of the Southeast Dermatology Specialist. Our speaker this evening is Dr. Mona Shariari, who is Assistant Clinical Professor of Dermatology, Yale University School of Medicine, Associate Director of Clinical Trials CCD Research, and Senior Editor of the Journal of Psoriasis and Psoriatic Arthritis in Central Connecticut Dermatology. We'd like to thank our supporters, Dermavent, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will appear. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the certificate of attendance will also be emailed to you. Again, if you want to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen, and I wrote a note there so you can see exactly where you need to type in your question. So without further ado, I will pass the floor virtually to Dr. Ujier.
Good evening. It is my pleasure to introduce Dr. Mona Shariari today in this webinar series. This is a series that is run by the International Dermatology Education Foundation, which was founded by Leon Kursic, a good friend of mine, but also the president of the IDEF. Leon is a clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai, as well as Indiana University Medical Center. And IDEF, when it was founded, had a goal and principal mission as a nonprofit to raise awareness and improve dermatologic care all over the world through education and especially in underserved area. So it is a foundation which has had many series. Many of you have attended in the past, and many illustrious lecturers have been part of these series, as you can see some examples here. Pretty much every week there's a new series and a new lecture with this on webinars. So Dr. Shariari, as Roxanne said very well, is going to talk to us today about VTAMA tapinarof cream 1% as a novel topical therapy for adult plaque psoriasis. At any time, please type your questions, and at the end of the lecture, we will discuss them with Dr. Shariari. Thank you, Dr. Shariari.
Thank you so much for that introduction, Dr. Ujier. So I'm very excited to be talking to you guys today about VTAMA, which is a next generation non-steroidal that's really changing our standard of care when it comes to treating our patients with plaque psoriasis. So let's dive right in. Just some housekeeping points. I am speaking on behalf of Dermavant and I am being compensated for this presentation. The content that we're going to review was developed by Dermavant and is consistent with the FDA-approved prescribing information for this medication, as well as all FDA-approved regulations. As such, I will be unable to answer any questions that go beyond the FDA approval at this time. So what is VTAMA's official indication? So VTAMA, aka tapinarof, is a 1% aryl hydrocarbon receptor agonist. That's a cream, and it's indicated for the treatment of adults with plaque psoriasis. Some adverse reactions that we're going to go through in much more detail later on in the talk to keep in mind is with VTAMA, we saw folliculitis, nasopharyngitis, contact dermatitis, headache, pruritus, and influenza. So throughout this talk, we're going to go through what is the unmet need currently in our psoriasis medication landscape. Then we're going to go through the science behind VTAMA, aka tapinarof, and why it's unlike anything we've ever seen before in this space. And then we'll do a deep dive into VTAMA's efficacy, safety, and tolerability, and we'll end on some practical points on how do you get started with VTAMA. All right, sorry, my mouse was not clicking properly. So in order for us to understand how VTAMA fits into this busy toolbox of psoriasis medications, it's important for us to just go through the unmet need that we currently have in the psoriasis landscape. So the majority of our patients with plaque psoriasis have localized disease that's amenable to topical therapy. And when you look at the AAD and National Psoriasis Foundation guidelines for the treatment of plaque psoriasis, you can see that topical therapies are a cornerstone, whether we're treating mild, moderate, or severe disease. In fact, over 85% of our patients with psoriasis are using topicals either as a monotherapy or in combination with systemic therapies, again, regardless of the disease severity. Now, even though a vast majority of our patients with psoriasis are using topicals, our current armamentarium of topicals does have some limitations. For starters, the majority of them broadly suppress inflammation, which means they're not necessarily targeted to the specific cytokines and pathways involved in psoriasis. Also, a lot of our drugs, they offer disease control while patients are on the medicine, but as soon as they stop, the disease comes right back. And a lot of our most effective medications are not suitable for long-term use due to concerns about tachyphylaxis, systemic and local side effects, especially when you're treating the sensitive areas. So we've all been there where you've had a patient who comes in, you give them one cream for the face, one cream for the body, a different one for the groin, and then you have them use the creams twice a day for the next 2 weeks, and then after 2 weeks, they use it on Saturday and Sunday, and they use another cream Monday through Friday, but if the disease comes back, they go back to that initial regimen, and then we send them home. And have we ever asked ourselves, what are we asking our patients to do? I can't put a moisturizer on my skin twice a day, and I'm sending my patient home with this convoluted regimen, different creams, different body sites, different weeks, and I'm basically setting them up for failure. And what happens? This patient comes back in 4 to 6 weeks, and without fault, they put that high-potency steroid on their face. So we really need to simplify the regimen. Give our patients one cream that they can use once a day on any affected area of psoriasis head to toe for as long as they want to, so they can effectively treat their psoriasis. So with that background information in mind, let's talk about tapinarof, the science behind it, and why, again, it's unlike anything that we've ever had in our psoriasis space. So VTAMA or tapinarof is an aryl hydrocarbon receptor agonist. What the aryl hydrocarbon receptor is it's a ligand-dependent transcription factor, which means it modulates the expression of different genes depending on what is bound to it. Now, this aryl hydrocarbon receptor can be found not only on the skin, but also on other barrier sites like the gut as well as the lung, and the main goal is that it promotes homeostasis in those sites. Now, as I mentioned, tapinarof is a first-in-class novel aryl hydrocarbon receptor agonist, and the specific mechanisms by which VTAMA or tapinarof exert their therapeutic action in psoriasis is not currently known. But what we do know is when tapinarof binds to AHR, that complex goes down to the nucleus and influences the transcription of a series of genes that have impacts at the level of the skin. For starters, they decrease the inflammation in plaque psoriasis by decreasing our Th17 cytokines like IL-17A, IL-17F, which we know have pivotal roles in the development of the signs and symptoms of psoriasis. Those genes also reduce oxidative stress by increasing antioxidant activity. They increase skin barrier normalization through an increase in those key proteins that our skin needs for its integrity, like filaggrin, loricrin, and bluecrine. And finally, we also see a reduction in inflammation through a reduction in our Th2 cytokines like IL-4, IL-5, and IL-13. So with that background information in mind, let's go into tapinarof 1% cream in more detail. For starters, what's on the label? So it's actually a very simple label. This cream is FDA approved for the treatment of adults with all severities of psoriasis. So whether a patient has mild, moderate, or severe disease, they're a candidate for tapinarof or VTAMA. And there's no label restrictions on the duration of treatment. So if a patient wants to use it for 2 weeks, 4 weeks, or even a year, they can safely do so without being concerned about tachyphylaxis. And it has a demonstrated remittive effect that made it into the label. This is one of the most unique features of this medication. And what that means is for those patients who get clear, they have a chance at an off-drug remission that's on average about 4 months. It has no labeled warnings, precautions, contraindications, or drug-drug interactions. It can be applied to all areas of the skin, so it's one cream, whether you're treating the face, the trunk, or the groin. And it's convenient once daily application, which is great for our patients who, let's face it, live busy lifestyles, and having them use a twice-a-day cream isn't always feasible. So now let's dive into the pivotal trials that gave us the safety and efficacy data for VTAMA. So this was Soaring 1 and Soaring 2. So we took patients, adult patients, ages 18 through 75, who had all severities of psoriasis, mild, moderate, or severe, and they actually could have had a BSA of up to 20%. So this was not an insignificant amount of psoriasis that we're dealing with in this trial. And we randomized those patients to either receive VTAMA cream once a day or vehicle cream once a day. And it's important to note that the vehicle is not a placebo. Vehicles have emollient-like effects, so we're going to see something when we have a vehicle in a trial. And the primary endpoint was looking at the proportion of patients who got to clear or almost clear with at least a 2-grade improvement from baseline at the 12-week mark. And we looked at some secondary endpoints as well. So what did we find? So on the left, you can see Soaring 1. On the right, you can see Soaring 2. And early on, you're seeing separation of the VTAMA curve from the vehicle curve, such that as early as the 4-week mark, we actually have a statistically significant number of patients achieve that endpoint of clear, almost clear, with at least a 2-grade improvement. When you follow these patients out to week 12, we see continued efficacy, such that at week 12, you have 4 out of 10 patients getting to clear, almost clear, with that 2-grade improvement, and that's 6 times more people in the treatment arm than in the vehicle arm. But we also looked at itch. So historically, we think of atopic dermatitis as being itchy, and we don't really think about itch in association with psoriasis. But I guarantee you, if you ask your psoriasis patients about itch, they're going to say that they're itchy. But we don't have an objective way to assess itch. So we have to rely on the patient to tell us how bad their itch was over the last 24 hours. And they give us a score from 0 to 10. And what's deemed a meaningful reduction in itch in the psoriasis space is a 4-point or greater reduction in itch. And that's what we're looking at here. So with VTAMA, what you see is there is separation of the VTAMA curve from the vehicle curve, such that at the 12-week mark, we see about 68% of patients in the Soaring 1 trial achieve that meaningful reduction in itch with VTAMA, and that is statistically significant in comparison to vehicle. But how fast did we see results? 2 weeks. We actually had a statistically significant number of patients achieve that meaningful improvement in their itch as early as 2 weeks after starting VTAMA. Now, another metric we looked at was PASI 75 response. Now, some people may criticize and say that, is PASI even appropriate when you're dealing with localized disease? And that's true. Sometimes a PASI score is not sensitive enough. to detect change when you are dealing with localized disease. So if anything, it tends to underestimate the efficacy of the drug. But let's see how VTAMA did when we looked at this particular metric. And what you see with VTAMA at the 12-week mark is about 48% of patients are getting to that PASI 75 benchmark at 12 weeks with VTAMA. And again, that is statistically significant in comparison to vehicle. And we're seeing that PASI 75 response pop up as early as the 4-week mark. So again, lots and lots of data to show us that with VTAMA, we're strongly controlling the signs and symptoms of psoriasis in our patients. But I always say we can talk about the data for hours, but pictures are where you can really see the impact that this medication is having on our patients. So just to orient you, we're going to look at some pictures coming up. We're looking at PGA scores and PASIs, which you're all familiar with, but we're also going to be looking at DLQI, the Dermatology Life Quality Index, which is a measure of quality of life. And anything over 10 signifies a significant impact on the individual's life. And we're also going to be looking at itch score. Again, the highest benchmark for itch is a score of 10. So this is a patient that started out with a moderate disease, PASI score of about 18, high levels of itch, that NRS score is a 9, and the DLQI is 11. So this is having significant impacts on this patient's life. At the 4-week mark, after being on VTAMA for about a month, that PGA drops down to a 2, so we're not at the primary endpoint yet. That itch score, though, look at it drop down from a 9 to a 5. That PASI goes from 17.6 to a 4, but importantly, look at that DLQI. That drops down to a 3. Look at that arm. So this patient at week 4, even though they haven't met the primary endpoint yet, he can put a t-shirt on, go outside, and not be worried that people are staring at the psoriasis on his arms. And that change in quality of life is really reflected in that DLQI that we're seeing here. And then we follow this patient out to week 12, and he's able to achieve that primary endpoint with the PGA going down to a 0. Here's another patient with psoriasis. This time we're looking at the legs. And we know that psoriasis on the legs has been historically hard to treat, but also even when we treat the rest of the body, it's one of the last places to respond. And this individual started out with a baseline PASI of 16 and a PGA that's moderate. And the DLQI is a 9, again, moderate to severe impact on quality of life. And again, very, very itchy with that NRS score at 9. And at the 4-week mark, again, you see a substantial amount of clearance. We're not at the primary endpoint yet, but this is a patient that can put shorts on, go outside in the summer and not worry that people are staring at his legs. And again, that quality of life impact is being seen in that DLQI that drops from a 9 all the way down to a 1. And again, we follow this patient out to the 12-week mark. The PGA goes down to a 1, so this patient meets the primary endpoint. And look at that DLQI, it drops down to the 0. Now, this is a patient that I would have never dreamed of giving a topical for their psoriasis. I would think this is a systemic candidate for sure. But let's see how they did on VTAMA. You see that the itch level is high, that NRS is 10, and even in the photograph, you can see the excoriation marks. So you can tell this patient is itching and scratching. And that PGA is a 4, so severe disease. And after 12 weeks on VTAMA, look at that arm. Look at how much clearance. That psoriasis plaque just melted away. The PGA is a 1, so this patient met the primary endpoint, and the impact on quality of life is down to a 0, and that itch score went from a 10, plummeted down to a 0. So this is completely shutting down this patient's itch. Now, we learn a lot from looking at patients who were successes in the clinical trial, but we also learn a lot from looking at patients that did not meet the primary endpoint. So this is a very interesting patient who had psoriasis on the hands. Now, we know psoriasis on the hands from the standpoint of the activities of daily living, day-to-day other actions that we do at work and whatnot can be very debilitating for patients. But from a psychosocial standpoint, it can also be devastating for patients. Because let's say you go to shake someone's hand and they pull away from you. Or you go to the grocery store to grab an apple. Now everyone stares at you thinking that you contaminated the produce section. So again, significant psychosocial impacts. And the impacts beyond what we can see are really clear when we look at that DLQI. It's at a whopping 4, which means this psoriasis is weighing on the patient pretty much every second of the day. And you see the PGA starts at a 3. at the 4-week mark, the PGA is still a 3, and that hand is not perfect. But that's someone, as early as week 4, they can shake someone's hand and not worry that that person's going to pull away. Maybe they go to the grocery store, they grab that apple, and they're not fearful that people are going to think that they're contagious and now they contaminated the produce section. And that change from a psychosocial standpoint is reflected in DLQI. We went from a 14 down to a 4 in as little as 4 weeks. And then at week 12, we see the patient's PGA is still a 2, which generally means there is psoriasis in other parts of the body, because again, we're looking at the whole patient, not just this photograph. But look at how much better that hand is. Even though this patient is not deemed a success by the metrics in the clinical trial, you see that DLQI drop down to a 1. So they may not have been a primary endpoint success, but this is someone whose life you've changed with VTAMA. Now, this is another patient, again, same scenario. He did not meet the primary endpoint. And at baseline, you see the PGA is a 3. Again, the DLQI is a 9, so we're seeing that moderate to severe impact on quality of life. And the itch score is an 8. And again, in as little as 4 weeks, you can see those psoriasis plaques just melt away. And at the 12-week mark, that PGA is a 2, which means this patient has not met the primary endpoint. But even as early as week 4, this is someone that can put a bathing suit on, go to the beach, and not be worried that somebody is staring at their psoriasis. So even though some of the patients in our trial were not endpoint successes, they were clinical successes, which can again have an impact on that patient's life. So now that you guys have seen that with VTAMA, we're effectively controlling those signs and symptoms of psoriasis, let's go into the final piece of the puzzle, safety and tolerability. So here we're looking at the most common adverse events that occurred in at least 1% of patients in the initial 12-week period of those pivotal trials. And what you see is we saw folliculitis in about 20% of patients. The majority were mild to moderate, and the majority went away without intervention. We also saw nasopharyngitis, contact dermatitis, headache, pruritus, and influenza. Now, it should be noted that folliculitis, contact dermatitis, and headache were pre-specified adverse events of special interest, which means as an investigator, I was looking for them. We also looked to see how much VTAMA is absorbed into your system. And for the majority of patients, over 96% of patients, the levels were below the quantifiable limit, so extremely limited systemic absorption. But to me, a measure of how impactful an adverse event is how many patients discontinued drug because of that adverse event. And what you're seeing here is less than 3% of patients discontinued because of either the folliculitis or the contact dermatitis. And what that means is for the vast majority of patients, even if they were having one of those AEs, they opted to stay on drug. Now, anytime I hear about a non-steroidal in dermatology, not even necessarily psoriasis, I get worried that this patient is going to call me back in a couple days complaining that the cream is burning and stinging. So Dermavant was smart. They actually proactively looked at the tolerability of VTAMA, in particular in those sensitive areas, which are more likely to show any signs of irritation. So we're talking the face, the folds, the genitalia, neck, axillae, gluteal cleft, inframammary areas. And they asked investigators to rate the irritation scores in those areas. And the investigators were looking for dryness, redness, peeling at the sites. And what you're seeing here is very low irritation scores, which points to a very tolerable medicine, especially in those sensitive areas like the face or the intertriginous areas. Now, we also want to see what happens after a patient is exposed to a drug beyond the 12-week mark. Because let's face it, psoriasis is not a 12-week disease, it's a lifelong disease. And so we do these long-term extension studies to get long-term safety data. But we also get some meaningful efficacy data that can be helpful to our patients as well who are looking for that long-term disease control. So the open label extension for VTAMA was Soaring 3. And this was a very unique trial, and I'll go through the reasoning behind that. So any patient that completed the pivotal trial, so the 12 weeks of Soaring 1 and Soaring 2, was eligible to roll over into the open label extension. And 92% of patients who were eligible did roll over into the open label extension. And this is unique because as a clinical trialist, sometimes I have to beg and plead with my patients just to get them to week 12 or week 16. So to have 92% of patients voluntarily go into the open label extension, I think is very reassuring. But then the study design got interesting. So patients were randomized to get VTAMA or not get VTAMA based on the disease severity of the psoriasis that they had. And what do I mean by that? So we asked an important question. If somebody is completely clear and we take their drug away, what's going to happen? And so any patient who was completely clear at the start of Soaring 3, we took their VTAMA away. And anyone who had even almost clear disease, so a PGA of 1, stayed on VTAMA until they got to a completely clear. And then if the disease came back, so they had mild disease or a PGA of 2 come back, we gave them back the VTAMA. So during the 40-week open label extension, we constantly had people coming on and off drug. And this was meant to mimic a real world scenario, because in the real world, the patient's not going to stop a drug when they're kind of sort of clear. They're going to stop a drug when they're completely clear. And they don't want you to take their drug away until they're completely clear. And what we're really looking for here is there any sort of durable off-drug remission that we see with this drug? And we actually had 73 patients who entered the open label extension with completely clear skin. And for them, we had the longest runway to see what the heck is going to happen. So remember those 73, we're going to come back to them in a sub-analysis that we do in the upcoming slides. Now, what did we find? So of the patients that were in Soaring 3, 41% of them got to complete skin clearance at some point during the 40 weeks of the open label extension. But interestingly, almost 60% of patients who entered the open label extension with mild disease or worse, they got to clear almost clear at least once during the open label extension. And what that shows us is that with VTAMA, there is that potential for continued efficacy the longer a patient stays on a drug. So if a patient is doing better at week 12 and maybe isn't at treatment goal yet, I suggest you keep them on the medicine longer, because there's a chance that peak efficacy may occur at a later point. Now, as I mentioned before, psoriasis is not a 12-week disease, it's a lifelong disease. So the ability of a drug to offer that long-term disease control is very important to our patients. And that's what we're looking at on this slide here. So disease control over time and that PGA score of 0 or 1 maintenance. And what you're seeing is a nice flat line, which shows us the durability and stability of response over the 40-week period. This is a dynamic graph, which means patients are constantly coming on and off drug, but despite that, we have that stability. If patients were losing efficacy, there was evidence of tachyphylaxis, the recapture rate wasn't good, we would see that line start to slant downwards. And again, that stability shows us that patients are able to maintain that durable response over time. But now this is the most important slide I'm going to talk about. Again, you can forget everything else I said. I just want you to focus on this. But this is where we're going to talk about those 73 patients that entered the open label extension with completely clear skin. So we did a sub-analysis. And the main reason we carved out these 73 was we had 40 weeks. So we had a long time to figure out what the heck happens if you take someone's drug away when their skin is completely clear. And what we found is if you're completely clear, your skin stays clear, almost clear, for a median of 4 months, which means for some people, the disease came back before the 4-month mark. But it means for half the patients, they actually stayed clear beyond the 4-month mark, with actually 13 patients staying clear at the very end of the open label extension. And when you look early on at the initial 25 to 30 days, you see almost everybody stays clear. So what this means for your patients is, let's say they're going on a camping trip, their skin's clear, maybe they don't take their VTAMA with them, or they're going backpacking in Europe for a week or two and they're completely clear. Maybe they don't take their VTAMA on that trip with them. So again, very practical for our patients. But what about all those patients that were in the open label extension? 41% of them got to completely clear skin. And of those individuals, they maintained that complete clearance for an average of 4 months. And really the ability of patients on VTAMA to maintain this clear or almost clear status off drug is the strength and really most unique feature of this medication. You basically have a chance at a durable remission off drug for on average 4 months with a once a day cream. When have we ever heard of that before? Now, as always, photos really can tell the story much better than any data slides can. So here we're looking at that same arm patient from before. And what you see here is after 12 weeks of being on VTAMA, the PGA score is a 1. So this patient continued on VTAMA. And at the 6-month mark, this patient got completely clear. We took the VTAMA away. And as we monitored this patient, over time, this patient stayed completely clear for 6 more months. And interestingly, look at that image from week 48. Even though the disease has come back at a PGA of 2, look at that arm. It's not nearly as bad as it was when we first started. So maybe in the real world, the patient doesn't go back to their VTAMA for even more time. So again, from a practical day-to-day for a patient, this is very relevant information. Now we're looking at another body part on that same patient. This is the abdomen. Again, at week 12, you see that the PGA score is a 1, so we do not take the VTAMA away. And then at 6 months, this patient achieves that completely clear skin, and we take their VTAMA away. And now again, their skin stays clear, almost clear, for 6 more months. And when the disease comes back, look at that abdomen. It's not nearly as bad as it was on day 1. Now, as I discussed earlier, these open label extensions are meant to be primarily safety studies. So of course, we looked at the safety of VTAMA during the 40-week period in addition to that pivotal period. And what we're seeing is the safety of VTAMA in the open label extension is consistent with what we saw in the initial treatment period. We're not seeing any new safety signals, no escalation of the previous safety signals. The majority of the treatment emergent adverse events were mild to moderate. It was at the application site and very low discontinuation rates during that time period. All right, so let's actually now shift gears and talk a little bit about an action that the National Psoriasis Foundation actually recently took. So when we're dealing with chronic disease, having treat to target goals can be really helpful to guide treatment decisions, especially when you don't know as the clinician, what is a good endpoint to shoot for? And this can help improve patient outcomes. We do this for rheumatoid arthritis, for example. When we looked at our psoriasis patients, we realized that we don't really have any treat to target guidelines, which was leading to a lot of our patients being not treated at all or undertreated. So the medical board of the National Psoriasis Foundation back in 2016, they decided to create some recommendations to better guide clinicians on what to look for as that final endpoint or that treat to target endpoint. And then this was meant to allow for better patient-centric care moving forward. So those guidelines included patients needed to achieve a BSA of less than 1% after being on a new drug for 3 months. Now, some of our patients are going to be slow responders. So an acceptable response was BSA of 3% or less after 3 months. And then you periodically want to check in with the patient. If they are at the treatment goal, you follow up every 6 months to make sure that they continue to stay at that target that we're looking at. So in order for us to see if our patients on VTAMA are achieving these stringent benchmarks that the National Psoriasis Foundation put forth, we did a post hoc analysis. And what we found was 40% of patients, after starting VTAMA at the 3-month mark, they were able to achieve that stringent treat to target goal of BSA less than or equal to 1%. And then we looked at all of our patients in that 52-week period. 61% of those patients were able to achieve those stringent goals with VTAMA as a once-a-day cream. And this is pretty incredible because we have some systemic medications that can't get our patients to this benchmark. So it was really reassuring to see a medication like VTAMA able to achieve this benchmark that the National Psoriasis Foundation put forth. But again, what does this look like? So this is another patient that we haven't talked about. And you can see he started out with a BSA of 15%. And at the 4-week mark, that BSA drops down to 0.3%. So this is somebody who has actually achieved those treat to target goals as early as the 4-week mark. And when we follow this patient out to week 12, that BSA is 0%. And you just want to check in with them every 6 months to make sure that they're maintaining this treat to target goal. But this is that hand person from before. So you see this person start out with that BSA of 17%, goes to 14% at week 4, and then 8% at week 12. And the reason I'm showing you this image is because those treat to target guidelines did not take into account patient-reported outcomes or quality of life metrics. And this is a perfect example of where this patient did not meet the treat to target outcomes. But as you can see, the clearance of the psoriasis on this patient's hand has significant impacts on quality of life, as we discussed earlier. So even though these treat to target outcomes are great to guide clinicians, it's not the whole story. And the burden of psoriasis oftentimes goes beyond the skin, and what you see is not the whole story. Now, you decide to put your patient on VTAMA. How are we going to get started with this medication? So for starters, what do patients think about this medicine? Because we kept talking about the trials and what the investigators thought. So 90% of patients say that VTAMA is easy to apply, it's not greasy, it absorbs quickly. My patients use the word elegant to describe the formulation. And 86% of patients said they could easily manage their plaque psoriasis with VTAMA, which is great because I always say the best cream is the one that you're actually going to use. And then 84% of patients said they would recommend VTAMA to others if it was available. Now, first things first, you want to identify the right patient for VTAMA. This is FDA approved for adults with any severity of psoriasis. So mild, moderate, or severe, they're a VTAMA candidate. And sometimes you might need to do a prior authorization. Now, as somebody who does a lot of psoriasis and I do a lot of systemics as well as topicals, what I'm going to walk through is always in my note, because no matter what I decide to do down the road, this just makes my life much easier. But make sure you have the correct ICD-10 code. So this is FDA approved for psoriasis. Do include a BSA. This is extremely helpful if a patient has a large BSA and maybe you want to get 2 tubes of medication approved. Make sure that you write down what they've tried and failed. So if they've tried a topical corticosteroid, maybe they've tried a calcipotriene type product. They've maybe tried a retinoid. Again, document these sorts of agents. And sometimes you might have to include your chart notes. I'll be honest, the PA process in my state, at least the state of Connecticut, has been pretty seamless. I send everything to the specialty pharmacy. I like to use Westport Apotheco, and magically something happens. The VTAMA savings card is applied and my patient gets the medication. But again, if you're having any issues, talk to your local representatives and make sure there isn't something simple you could be doing to navigate that. And I have to say, VTAMA is now on formulary with a lot of insurances in my area, which has made the process even easier because I don't have to send it to the specialty pharmacy for every patient. How do we apply it? How do we store it? Patients just need a thin layer once a day, and you want to avoid using it on unaffected areas. This is not a moisturizer, and wash their hands after you use their medication, and please do not eat this medicine. That being said, it is gluten-free. You want to store it between 68 to 77 degrees, so pretty much room temperature. Don't leave it in a hot car, don't freeze it, and then keep it out of the hands of children. Now, VTAMA has been around for a year, and in this short year, it has become the #1 prescribed branded topical for adult plaque psoriasis. We have over 140,000 prescriptions filled, 10,000 unique prescribers, and then over 2,000 pharmacies where the MyVTAMA card has been applied. So they hit the ground running, and really this medication is making an impact on our patients, which is why I think so many of our peers are getting on this bandwagon. All right, so let's bring it home. I went through a lot of information for you. So what are your key takeaways? So just remember that VTAMA cream is a 1% non-steroidal, it's really a next generation steroidal that represents a new standard of care for your patients, adult patients with plaque psoriasis. With this medicine, we see powerful efficacy, with 6 times the efficacy with VTAMA versus vehicle, and 4 out of 10 patients getting to clear, almost clear, with at least that 2-grade reduction from baseline at the 12-week mark. Those results last, so we see that durable disease control over time during the 52-week period without any tachyphylaxis, and it is the only branded prescription that has this demonstrated off-drug remittive effect that's in the label. So for those patients who get completely clear, they have a chance to stay clear, almost clear, for an average of 4 months with a once-a-day cream. It's safe and well tolerated. We don't have any label restrictions on the duration of the use, no labeled warnings, precautions, no contraindications, no drug-drug interactions, and it can be used on all the severities of psoriasis, on all affected areas, and even in sensitive sites. And it's been shown to be tolerable and tolerated very well in those sensitive sites. So my take-home point for you guys is really, let's empower our patients. Give them one cream that they can use once a day for any severity of psoriasis to any affected area, including those sensitive areas, for as long as they want to effectively treat their skin disease. And with that, I thank you for your attention, and we will open it up to questions.
Thank you, Dr. Tariari. One of the questions from Ibrahim asked if this is a PDE4 inhibitor. Would you go over briefly over the MOA again, if you don't mind?
Absolutely. This is not a PDE4 inhibitor. It's an aryl hydrocarbon receptor agonist. This is a very unique mechanism. And basically, the aryl hydrocarbon receptor is a ligand-dependent transcription factor, which means depending on what's bound to it, it modulates the transcription of a different set of genes. When tapinarof binds to AHR, we get transcription of genes that play a role in promoting homeostasis at the level of the skin.
Perfect, thank you. Another question that that was asked, and I know you know the answer, but I'll let you answer it, is there any need for labs?
There is no need for labs. So in our clinical trials, we actually did not see any difference between the labs in our treatment group as well as the vehicle group. So it's easy. You don't need to check labs.
Perfect. And would you expand in, you know, we all use it and I've had really good success with it as well and have not had any major issues with the patients, but every now and then I have patients who seem to have a little bit more of an irritation to it. And I find mostly that this is caused by very specific ways that the patients themselves apply this. Would you expand a little bit about what would make it, what to do to help prevent these issues if they ever come up?
Yeah, so in the clinical trials, we did see some contact dermatitis, for example. Nothing like patch testing was done, but it's that sort of junk term where there's some irritation at the level of the skin. Generally, I have the same experience as you. I have seen a much lower incidence in the real world in my clinical practice, because when you're doing a clinical trial, it's an adverse event of special interest. You're really looking for it. But what I find is if a patient comes to me having this sort of an adverse event, it's generally because they're not using the medication correctly. So you want to use a thin layer. I double check that they're using the medicine once a day, because let's face it, we've always given them twice a day creams, and a patient gets the box and they throw away the box that has the instructions on it. So a lot of times they just go back to their old habits. I double check my prescription and make sure that my scribe did not change the directions. I've had that happen a couple of times. And you also want to make sure they're not using it as a moisturizer in areas where they didn't have psoriasis, because the elegance of the vehicle does make it really easy to use it everywhere, but you really want to hone in on the areas where you have the plaque psoriasis.
Perfect. I found the same issues as well. If I've ever had an issue, usually it's because it's been used incorrectly. Question from Maha Lutil: how are you treating the folliculitis if it shows up?
So great question. In the clinical trials, we actually had a majority, 72% of patients who did not need any intervention at all. So you either treat through it or you stop the medication, it goes away, and then you go back on the medicine. And that's what I've been doing in my clinical practice. I haven't had anybody that's needed an actual intervention. We did have about 30% or so of patients in the clinical trial who did use an intervention. It wasn't consistent. It varied from site to site and depending on what they were seeing. So far in my clinical practice, either stopping the agent or treating through it has been enough to get it under control.
Perfect. Perfect. I think, let me see. I'm looking at all the questions here. Most of them have been answered. Do you have a preference or predilection where you would use this as on certain areas of the body or not on certain areas of the body?
I use it on any affected area, honestly, because I think that's the beauty of having this once a day cream. It makes that conversation with my patient easy. If they have psoriasis on the face, if they have it in the groin, if they have it on the trunk. And remember, patients oftentimes have psoriasis in areas that they don't tell you about, but they assume the cream you gave them is going to work. So that's why I think this makes the conversation easy. You just give them that one cream and you know, even if they use it somewhere you didn't know about, you shouldn't have any issues with adverse events.
Perfect. Same here. We use it everywhere. It's one of those things that, you know, one cream helps and is applicable everywhere as long as you use correctly. All right. I don't see any further questions. Is there anything else you'd like to add, Dr. Shariar?
No, I think that it's a great addition to our psoriasis toolbox. And if you haven't tried it yet, I would give it a go because for me, at least, I'm noticing a paradigm shift where I'm reaching for this over my topical corticosteroids. And I think just from a conversation with the patient standpoint, overall ease of mind, from a safety standpoint, when the patient goes home with the cream, it's really made my practice much better.
Great. Thank you so much. Roxanne, I'll hand it back to you.
Well,
Thank you, guys.
So much, Dr. Shariari and Dr. Gugier, for this great presentation on this wonderful new modality for psoriasis patients. And we'd like to thank you all for joining us this evening. Stay tuned for our next International Dermatology Education Foundation Educational Series webinar tomorrow evening, as well as next Tuesday on HS. Good night, everybody.
Bye.